Okay, so introductions. I'm Britton Ethridge. I'm a fourth year medical student about to graduate from the Alabama College of Osteopathic Medicine. Been an SMA committee member since the end of my first year, I guess. I went to present at this conference in Memphis, and wanted to join a committee. And so I've been active with SMA since then, and I'm a part of the outreach subcommittee.
I'm Michael Braman. I'm a third-year medical student from the University of Kansas School of Medicine. Interested in basically surgery, critical care, and I've been involved for the last couple of years as well. And I also got involved basically in the same setting that you guys are in, kind of presenting at this conference. It's really been a wonderful experience. So
All right.
looking forward to talking to you guys today about kind of some of the experiences that we both had. I know Britton's going to kick us off here, just kind of speaking about not only our experience in research, but also kind of particularly to low resource settings and kind of getting involved in international health and those types of things as well. So I'll let Britton kick it off.
All right. So if we're talking about expanding care in low resource settings, I thought it was great to start with what defines a low resource country. So the World Health Organization defines it as a gross national income per capita less than 1,045, which is hard to maybe to have reference for. So I decided to put the countries listed on there so you can kind of see where people generally fall across the world. There's this big gap from the top of the high income country list even to the bottom of the high income country list, going from about 100,000 per capita down to like 14. That's a big spread. And so when we get down to actually officially low income countries, that's a per person income of only $1,000 a year, which is pretty crazy if you think about it. And then also, this is where some of the counties are that are nearby to here for reference for what it might feel like. So again, here in Birmingham, per capita income is about 71,000 per capita. Again, not even just the nice neighborhood maybe you drove through on the way to have a drink last night or whatever. So, but then how is expanding healthcare access unique compared to just what we should be doing every day anyways? I would say it's the goal in expanding healthcare access is to eliminate the barriers. Otherwise, you're just providing good medical care wherever you're at. But if you're expanding it, you're just taking down things that people can get care where they haven't had it before, right? So what are the barriers? Um, I went through several systematic reviews and to try to really quantify and clarify what they are. I selected three to put on this slide here. So this is one of the widest reaching ones. It included 43 actually in the final review from all the countries you see there listed. In order of how many reviews were used from each country. So most were from Canada, Norway, and the USA. And the summary of the research question is, what were the challenges to healthcare service delivery and access are addressed in contemporary literature? And basically, physical geography or lack of transportation was the biggest in that review for all the countries, and a pretty big gap between that and provider availability, which could be taken as, who's willing to actually physically go out there, but also sometimes appointment availability, just long wait times in clinic and actually getting seen by the providers. Language barriers, of course, are always an issue, and systemic factors. And then when the study broke that down, the biggest systemic factor was the inability to pay or a lack of insurance and assumed inability to pay. So then focusing in on ophthalmology, because that's my pet passion that I am pursuing. Affordability was actually the number one reason in USA and Nigeria, which is where most of the studies were from, most of the publications were in this study. But then interestingly, awareness and transportation or lack thereof were equal. 75% of patients who said they weren't able to access care noted that just the perceived need or perceived benefit or inability to get there were equal. And again, 75% of patients who actually responded to the survey said that they had issues with that. And also provider and appointment availability was number 4 there. And then I tried to get into another example of more of a low resource setting specifically. And this one was a cross-sectional survey with an N of 4,300 though. And it was kind of the same, just in a different order for the reasons why people aren't able to get care. I thought it was important to note for the first study, because it had the best research power, the research question inherently excludes awareness as a possibility for a barrier to care. And we'll get to that later. So the summary of it is awareness actually overall was the most common reason for all studies in all settings in all countries. And that is somewhat, broad. And so patients, a lot of times, whether it was for ophthalmology or for whatever their primary issue they went was, they didn't see the benefit in going. They're like, I'm not any different today than I was yesterday. And so especially for glaucoma or any of those like long-term diseases, that's always a struggle regardless of income and setting, is people say, I don't feel any different. This isn't helping me. And so they just don't go back. Um, or also just care coordination and like unawareness of the need to follow up, not having good teaching at their first clinic visit. They thought they had surgery and they were good for their, trabeculoplasty and their pressure is going to be down. I didn't realize they had to follow up. And then the others on there that you see. So I wanted to share two organizations I've worked with and what they've tried to do to expand healthcare access, and then learn some of the difficulties they've had and then how they've overcome them, and then suggest maybe the things to focus on if you're still trying to expand healthcare access. So Servants for Sight is a nonprofit based out of Greenville, South Carolina, that just tries to help upstate South Carolina get more access to ophthalmic care. So what their process is, local physicians or physicians who were actively part of the Servants for Sight organization will refer patients to the service, or patients can self-refer if they have awareness of it, and they try to do, fundraising or publication, flyers, and just run campaigns and ads on TV and everything. And then they'll send out the mobile Servants for Sight clinic van to give people access to at least get screened. Like, hey, we'll go to the county fair or whatever else, just so you can actually see if you really have a need. Because a lot of people just be like, no, I've always seen this way. I'm fine. This is what it's supposed to be. I don't really need that peripheral vision I don't notice I don't have. And so they send a van out there, and then people are either registered for the program at that point, and then they are just asked if they are able to pay a certain specific designated fee. They're scheduled with a physician until they have 9 months to get any amount of care that they need to get, whether it's the surgery or just, prescriptions in clinic. It's like a $50 fee, and then they can do anything they need to in that 9 months, and then they roll out. And at their first appointment with the physician, they're actually referred to like financial rehabilitation support services, offered job coaching, other education. It's kind of like a small job fair, their first visit as well, just to try to help them get out of the circumstances that they're in. So my first med school project, like at the end of my first year, was with Servants for Sight. They asked me to figure out, okay, our biggest question we have is why are patients lost to follow-up? We get a lot of people in, we get tons of people, we have tons of appointments set up, but then nobody shows up, and we told them they have a need. So they asked me to try to go through all their data and figure out why. And so myself and a group of a few other students found that when we did a linear regression of all the variables they suggested, the only statistically significant factor for missed appointments was a low rate of bachelor's degree in that community, which was interesting. We thought it'd be something else, about price or still logistics, but for them, the only statistically significant factor was that one. ACE Global is an NGO based out of Florida that operates the only fellowship program in Honduras. Now, Honduras is very interesting because they have, I think this is the second largest population in Central America. It's like 15 million people in the country, but they only have one ophthalmology residency in the country, and it has 2 residents per year. And then they didn't have any fellowships until ACE Global came in the country. And the residents, truthfully, a lot of times graduate the residency program without any surgical skill or experience at all. It's very competitive to get patients down there, especially ones who can pay. And so a lot of times people don't get surgery because they can't pay, and the current attendings kind of oust them out of the positions to operate. So ACE Global started this fellowship to try to increase, competency down there and give people a reason to stay. Because a lot of times the surgeons who left the residency wanted experience. They would go to Mexico or the US or somewhere else to get fellowship training and never came back. So they have a real strong need for ophthalmic care in Honduras as a country, and especially in the larger urban centers. So the ACE Global started a fellowship. They have fellows that are there all year. They have 4 fellows now that are always on the ground, and they rotate US-based brigades and teams to come up their surgical volume, bring equipment, and they're getting free clinic space rented from like Catholic missions and other just organizations that are willing to donate it. And so the patients are recruited or screened by community health workers. That was one of the biggest things that we realized early on after about the first year we needed to expand was people just didn't even know they had an issue and never really considered it. And so educating one person and sending them out to whatever mountainous place that's difficult to get to and letting them be a primary care provider, basically, and having just a printed textbook manual that we have of, basically it's like the first aid for USMLE book of what you need to look for glaucoma issues or all these other ophthalmic diseases really helped get their volume. And they also have some pop-up clinics, but mostly it's the community health workers putting on consistency that brings people in. So then they're seen by Hunter and fellows in free clinic space that they have every week, and their income is verified to be seen in the free clinic and get free surgery, usually cataract surgery. And so they're scheduled for surgery at one of the free sites, like I mentioned. During the brigades, we'll have 8 or so attending physicians come down from the United States, operating simultaneously in very tight quarters, and we'll do like 100 cataracts in a week, which is great for the fellows because they're doing live stream teaching the rest of the year when brigades aren't there. And so they have local attending physicians that are partnered with, but they're just going to be, you know, 10, 15 minutes, maybe an hour down the road. They could get there if there's a problem, but it's just different. It's nice to have somebody on site with you. And so after the brigades leave, especially, the follow-up is with the Hunter and fellows back in the free clinics. And so ACE Global really has great recruitment. They're overwhelmed with intake. There's too many people. That picture is just from one of the days that I took that picture outside the clinic before we operated one day. They had great clinical and surgical outcomes by measurements, which is a nice thing about ophthalmology. You can ask the patient to read off the chart. They tell you like, no, I can't see that. I read 2100. But then you can do an A scan of their eye and you're like, actually, the optics tell us you're reading 2030. Sorry, your cataract surgery and lens placement is great. And so they have great surgical outcomes objectively, but an increased work among the population. But the biggest thing is they just don't have the clinical space. They said they needed to increase funding and they're trying to figure out how to do that. And also, we did a survey after our first year of having a full year of work down there and noticed that patients were actually more anxious and depressed and expressed dissatisfaction after successful surgery, which you wouldn't really expect because most people were going from very visually significant cataracts to having clear vision, maybe just a little bit blurry if they're trying to read a book. And so we really didn't expect that at all. And so ACE wanted us to follow up the next year, which we've already finished, to try to see why people are dissatisfied and why this isn't working, right? And for them, drum roll, we found that patients just thought their outcome would be different. They're like, we had this surgery with the free, amazing lens that's inside my eye forever. I thought I was going to be able to see. I still can't actually sew. I still can't actually work on my car. And people didn't understand that, there's with a fixed lens and not your natural lens, there's going to be a loss of that clarity and depth. You have to kind of sacrifice either distance or near vision unless you have a premium multifocal lens, which isn't even perfect here in the States, for people who can afford them. And so the easy answer is supposed to be reading glasses, but a lot of people didn't get them or didn't know they needed them or lost them and couldn't get back to get them. And reading glasses here in the States, everyone can get them at Dollar General literally for $1. And they can have 40 pairs around the house. Most patients who are of cataract age have a lot of them around the house. So what are the modifiable barriers that these studies suggest people have for getting good healthcare, at least in ophthalmology? Awareness and health literacy in the literature and in the studies that I've been able to participate in the States and abroad is still the biggest factor in people not having a good outcome and just not even wanting to seek care. They don't understand the need that they have, or they think that their result is supposed to be different. And of course, the others on there are still very significant, but the biggest one seems to be awareness and health literacy. So what factors affect health literacy? Um, Actually, because we have extra time, just to be honest with you guys, one of our presenters had to reschedule for an unforeseen circumstance. So who was going to maybe suggest, if you would, what do you think is big factors affecting health literacy worldwide?
Education.
For sure. Right. Thanks, Buckley.
Access to.
Access to education. Okay. Yeah, great. Perfect. Because Google Translate is not a perfect translation. You're totally right.
People are worried about food, why would they even care about?
Yeah, for sure.
Is your family health literate? Has anyone in your family been health literate before? Do they encourage that for you?
Right. Yeah, that was also something that I was really surprised to see, that people who were offered free cataract surgery and a van to take them there, a lot of times still said they weren't able to come unless some other family member was able to come take care of whatever responsibilities. And, that's the thing everywhere. It's not like those needs go away if you're in a low resource setting or not. Um, so yeah, the biggest one is just the financial deprivation for the two studies cited there. You can see at the end is actually the biggest determiner of your health literacy, social status and support, education, age, and gender. So, you can't, as a physician, as a missional physician, as someone who really wants to go and help these low resource settings, you can't necessarily affect any of those. So what can you actually make a difference in? You can offer your services and equipment for free, and you can try to educate your patients better throughout every step of the process. So maybe the refined goal should be to create a self-sustainable method of providing effective care for patients who cannot otherwise access their medical care due to modifiable factors. And those are the factors that you as a physician have the ability to actually change for your patient. So to summarize, patient teaching, it sounds like a medical school mantra, at least at mine, but really educating your patients at every step of the way and offering teach back time for them is so important. People, especially if there's a language barrier or if they're being offered free or reduced cost care, they don't want to say anything that messes it up maybe. And like, are you going to exclude me from this service? Maybe they just literally don't understand. But educating them is just super important for their outcome, whether you're in an affluent area of the US or Norway, or you're in a low resource setting in Honduras. People just need to know because they don't have medical training. And as you all know, this is so much harder to learn than you probably thought it was before you started. And so filling in the gaps in a way that makes sense to people in plain language is so important. Outreach isn't effective to have mobile and pop-up clinics. It's very effective for the organizations I've worked with. They're overrun with people to help. And then a tiered payment model that we did in Honduras was much better at raising the funds needed. They're actually building a surgery center now, and they're able to offer another physician's position. They're able to offer and start their own clinic space and have more appointment availability. So having a tiered payment model with verified income where you can pay nothing if you have it, or $10, $50, or up to the full price of the surgery is arguably the most effective way to actually keep your service running in a way that is not a burden to the people who need care, but also pays your physicians and gets you the equipment that you need. Here are my references. Thank you. Yeah, we had a matrix broken down, and there's, like in Honduras, system in Pura, we had a system verified by Honduras, breaking it down into like 5 different categories. And we had a fixed payment for if you're in this category. For the lowest one, it was free. Next up, it was literally like the equivalent of $10 or something. So
So we're gonna change gears just a little bit. We're still, thinking about international health, and Britton did a phenomenal job kind of setting up some of the main kind of common threads that you'll see that we follow kind of throughout, and some ways to think about it. What I'm going to talk to you about today is my kind of experience both with international health and international research, and kind of how we've applied a little bit different model to kind of global health and how in kind of tackling some of the problems that we've highlighted, particularly in kind of low middle income country settings. So just to start with some background on me, so I'm a Kansas kid through and through. Born and raised in Kansas. My mom's side of my family actually immigrated from Ireland to kind of rural Kansas. And the unique thing about Kansas is, has anyone been to Kansas? Oh, that's actually way more than I thought. Cool. So Kansas, which is not uncommon from a lot of the Midwest and a lot of the South, we have kind of two major kind of heavily population dense areas. So kind of in the northeast corner, that's where Kansas City is. 50% of Kansas City is actually on the Missouri side, and it's like the better part too. Like they have the Chiefs and all that. So we're a little bit bitter about that. But obviously our big metropolitan area there, and then we've also got Wichita, Kansas, which is more kind of south central Kansas. But then the rest is very spaced out, very rural. So kind of as someone who grew up and who had family who lived rural, always kind of saw discrepancies in healthcare and particularly access to care, health literacy, all these things that we were talking about. And then as an undergraduate, I pursued engineering. I've always been kind of problem solution oriented. So I was a biomedical engineer before. And the thing that I've always been interested in is kind of seeing the overlaps that we can see between the need in a global health setting in low to middle income countries and how those parallel the needs in our rural communities. So kind of thinking about that and applying lessons that we can learn from international outreach and international work. And then kind of, not only how did those impact us in our treatment of patient care in larger population settings, but also, how can we use the lessons learned there to kind of help out, folks in our rural communities that, that we're surrounded by, whether that's family or, folks that we know. I'm involved in a group called the International Orthopedic Trauma Collaborative. So this is kind of like a pretty rapidly growing group. When I started, it was actually called just the African Trauma Initiative, and then we've expanded to be pretty multinational at this point. And this work was started by my mentor, Dr. Archie Headings. He's an orthopedic surgeon at KUMC. And he was someone who spent a lot of time after he was finished training going out on mission trips. And the thing that he relayed to us in kind of his passion and starting to think more about, how can we improve global healthcare and global research is, this feeling that you go on a mission trip and you're there for however long you're there and you operate a lot, you do a lot of great work. But just feeling like there's something that he wants to do to have a more lasting impact, whether that's education, like we mentioned, is one of the biggest things that can be done, particularly for us at kind of our stage of training. Education is one of the things that we can contribute, right? But then additionally, grew into this really unique surgical fellowship. So now something that we do yearly is bring over a surgical fellow. So an African surgeon comes and trains with Dr. Headings, focused on orthopedic trauma. So for those who are less familiar with orthopedics, in terms of fellowship possibilities, orthopedic trauma really focuses on high energy trauma. So a lot of that is motor vehicle collisions, on the job accidents, those types of things. It's particularly pelvic and more specifically acetabular pathology. So acetabulum, where our femur, the ball of our femur sits in that socket is acetabulum. Just because of the way kind of our pelvis and our acetabulum is shaped, it's incredibly difficult to manage those things in the orthopedic setting. And when we think about low to middle income countries and why that becomes important is, as with technological advancement on a global scale, these countries become more industrialized at a rapid pace, and the healthcare infrastructure doesn't keep pace with that. So particularly in the setting of Africa, where we work a lot with, there's a lot of outside investment, mainly with the hopes of kind of getting a lot of the natural resources that you can find in Africa. So there's a lot of outside investment in industrialization. So countries will come and build roads, and then with this infrastructure, a lot of folks are driving around in cars that don't have traditional safety measures, whether that's seat belts, airbags. And then we end up having a lot of, these high energy trauma mechanisms. And the important thing for that is actually kind of at this point in Africa, trauma is constituting more significant impact on disability adjusted life years than tuberculosis, malaria, and HIV combined. And it's something that doesn't get talked about a lot because it's really challenging to understand how to manage that. So in terms of kind of Dr. Hang's thoughts, he really very much was kind of hoping for the butterfly effect of, can I bring a fellow from Ethiopia, train them on how to manage some of these more unique acetabular and high energy trauma pathologies, and then they can go back and they can serve their communities, and they can we can have this very formal knowledge exchange, and it's been tremendously successful. We now have a team of greater than 30 people, including the physicians that we have on board, both surgical and non-surgical physicians. We've got a nursing team. We've got a team of medical students. And then we've also had this really unique, we have multidisciplinary undergrad students. So we involve non-medical students from the University of Kansas campus in architecture, business, film. We've got a media and marketing team now too. So just kind of bringing everybody in with the hopes of expanding awareness of kind of global health and kind of inspiring our students. In terms of our kind of the three main countries that we work in, Romania, Ethiopia, and Zambia, we're also more recently in the last couple months, also have some relationships forming in the Congo and Rwanda. So I actually really love that Britton kind of had the chart, kind of countries broken down by GDP, so we could actually kind of see. And one of the unique opportunities that we have is with some of the diverse relationships that we have also in Europe is kind of getting exposure to kind of different levels of that. So going from very urbanized setting, kind of in Kansas City metropolitan area at a very large level 1 trauma center, to a smaller town of about 100,000 in Romania. That's a town called Bursan, with a hospital called Mavramati. And then Ethiopia, Addis Ababa, gigantic population center, but a very small healthcare infrastructure. So in terms of kind of how we've conceptualized these relationships and facilitating kind of a knowledge exchange, I've highlighted kind of Romania and Ethiopia where we have the biggest relationships, and kind of the things that we've done there and how that has informed not only kind of our relationships there and the healthcare in that region, but also how we'll take those lessons learned and apply it to our healthcare at KUMC. So to start with Romania, I went to Romania at the end of my first year of medical school and spent just over 2 weeks kind of just going, learning, both from orthopedic surgeons and anesthesiologists, critical care there as well. And one of the biggest things that we learned just in observation, I spent a lot of time talking about the anesthesiologists and the orthopedic surgeons there about pain control. So obviously, we're all familiar with the opioid epidemic. Unfortunately, it looks like with some of the more recent data that the FDA put out in the last year or so, it looks like we're starting to curb some of the death, but it's still, far too significant. But, awareness is increasing, which is positive. And the unique thing is, and what can be learned kind of from these international projects is they use a medication that's not used at all in the United States. It's a medication called metamizole, which is very unique. It's non-opiate. It has it's essentially would fall in the class of an NSAID, but it's somewhere in between ibuprofen and Tylenol. So it's got kind of dual mechanisms. So it has some COX inhibition, like we would think for a normal NSAID like ibuprofen, but it also has some effects on endocannabinoid and opioidergic signaling like Tylenol. So it's very unique. And you'd never come across that just kind of practicing in the United States. You'd never cross your mind. And the lessons learned that we've learned from that, and also their use of, they very sparingly use general anesthesia. They perform pretty much all their operations under regional, which sounds kind of wild for a lot of us in the States. But they, it's funny, you talk to the folks there about it and say, oh, this is a huge difference that we have. And they go, hey, don't you know that like general anesthesia is really dangerous? And I'm like, yeah, I guess. And they're like, oh, don't you know opiates are like really dangerous? You guys use them a lot, right? I was like, yeah, you're right. So just being super open-minded when you go, I know it's easy to, when you kind of go out on any of these kind of explorations in international health, it's easy to think that, your team is like the one going somewhere to contribute something, but really just kind of approaching all of this from a really open-minded perspective of, very much in how I've phrased it here, what knowledge can be exchanged to better kind of, all of us in our clinical practice. So the lessons that we've learned from that in Romania is actually most currently led to an opioid-free pain clinical trial that we're running at KUMC. So we have over 100 patients that have resulted back from that. It's been very encouraging. And these are folks that are still, have very high energy traumatic orthopedic injuries, and we've been able to kind of curb a lot of the opiate usage, kind of taking the lessons learned from Romania. And then on the Ethiopian side, we have the trauma fellowship like I described. And then we also conduct a lot of trauma research. So things like considering, how can we best treat trauma in the setting of, reduced access to whether that's orthopedic instruments or, you have 2 ORs. And, for example, their current orthopedic waiting list in Addis Ababa at the hospital that we're partnered with at ABET is over 5,000 people waiting to receive orthopedic care. And these are people who have injuries that, we can't imagine leaving the hospital in the United States. So kind of learning, whether that's an optimization, thinking about optimization algorithm of who does it make the most sense to treat first to try and optimize getting through a gigantic backlog like that, things of this nature. And then additionally, and kind of one of the more unique, exciting things is we're actually trying to build a hospital there right now through this collaborative. So in terms of taking all those lessons learned from applying the trauma research to a potential hospital build, and then also having our trauma fellows. It was actually interesting. One of our trauma fellows actually just opened the first foot and ankle clinic in Ethiopia and also in the greater area. So he'll serve greater than 10 million people. And that would be the only foot and ankle clinic that you could go to if you needed foot and ankle orthopedic surgery. And then all of that is just to highlight, improving our trauma care at KUMC. So thinking about kind of timing of surgical repair, what things can be managed non-operatively with good outcomes is another thing that we've spent a lot of time thinking about and learning from those collaborations. So just to kind of summarize, why get involved in international healthcare? So studies have shown, particularly in the setting of medical students, as we progress through our medical training, there's very consistent studies that show that we get more cynical. We get desensitized to things that we used to feel very empathetic towards. We get burned out, obviously. One of the foremost challenges that we're having, particularly in the post-COVID era, is dealing with burnout. And uniquely, participation in international healthcare, particularly when you start that as a medical student, has shown like pretty consistent reduction in burnout and increases in empathy. And those have been pretty sustained even after you've kind of returned from any of your international work. And then again, kind of what I alluded to at the beginning of the talk was understanding how practice in a resource-limited setting, whether that's internationally, and kind of how you can take lessons learned there, not only to produce you as a more well-rounded physician. You understand, maybe there's only one medication available for a certain treatment and you're less familiar with that medication. Now you understand how to treat whatever pathology with more limited resources. And then also kind of the one that I alluded to that, I'm really passionate about is how you can find those overlaps with rural healthcare in your surrounding communities. I think it's a gigantic one. So obviously huge, potential for impact kind of doing this work. So I think that's a lot of what I wanted to talk about. I'm happy to take any questions. I know both of us are, but thank you all so much.
Please support our mission to improve quality of patient care through education. Join us, follow us, and share this content with family and friends.